Welcome to the webinar Immediate Complete Dentures from Extractions to Aesthetics. This lecture is being presented by Wendy A. Clark, DDS, MS, FACP, and we're going to begin shortly. And with that, it is my pleasure to introduce Wendy A. Clark, DDS, MS, FACP. Dr. Wendy Clark completed her undergraduate training at the University of Georgia and earned her doctoral degree from Marquette University School of Dentistry. She then earned her master's degree in clinical dentistry and a certificate in postgraduate prosthodontics from the University of Alabama at Birmingham School of Dentistry. Dr. Clark practiced prosthodontics for 7 years with Team Atlanta and lectured nationally on a variety of topics, ranging from smoking cessation to dental implants. She was named a leader in continuing education by Dentistry Today in 2017. And currently, Dr. Clark is full-time faculty at UNC Chapel Hill Department of Prosthodontics. And it is my pleasure to say, take it away, Dr. Clark.
Thank you so much, as always, for that introduction. I am excited to talk to you today about complete immediate dentures. You can see the learning objectives here on the screen. We will go through each of these as we roll along. And last but not least, here's my disclosure. I am a consultant for a lot of different denture companies, but none of them are sponsoring me today for this webinar. So my love of teaching dentures was inspired by one of my dental students who came to me and told me that his mentor said he will not be able to afford to make dentures this good ever again, which is kind of devastating to hear as an instructor that that's kind of the peak of your denture game is as a third or a fourth year dental student. But kind of the moral of the story is going into practice and being in a busy practice, he didn't feel he'd be able to take the time to pay attention to each of those steps. So one of my goals as an educator is to try to empower my attendees and my students to feel confident making dentures that they can feel proud of. And it's not just my poor dental student. When I was doing some very serious research on a very serious website called Reddit, I searched to see what people thought of as the hardest class in dental school. And not surprisingly, many of them thought that dentures, complete dentures, was one of the hardest classes they ever took. One of my favorite quotes is this one that says, "My personal hell would be an endless line of occlusion rims." But truly, it can be a painful experience, especially as a novice clinician who's not familiar with kind of the reasoning behind some of the steps and kind of the clinical decision making that you gain with practice. And kind of going back into the literature as about 20 years ago when I was in dental school, there was a process, a thought process, not only in the United States in the JDE, the Journal of Dental Education, but also globally in some of the British and European dental journals, considering whether or not we actually needed to teach dentures to our dental students. The thought process behind that was with declining rates of edentulosum, soon there wouldn't be enough patients for general dentists, and so all these should be relegated to the prosthodontic specialists. Fortunately, we have moved away from that thought process and discovered that we do, in fact, still need to teach complete dentures. And now we've completely changed our thought process. And not only do we need to teach dentures to our dental students, but perhaps we should consider teaching everybody digital dentures. And this came out of the Loma Linda group with Charlie Goodacre and Brian Goodacre, where maybe we need to be rethinking some of our curriculum. I feel really fortunate to be at a time in clinical education where we're not only teaching kind of that foundational principles with the conventional workflows, but also adding some of the digital technology to expand that concept. And going back in time to 2016, when we first started teaching digital dentures, there was a survey that came out of University of Florida to find out what people were teaching nationally. And at that time, only about 12% of dental schools were teaching digital dentures at any level at all. So it could be just even exposure didactically to a lecture like this one. But fortunately, today, not even 10 years later, we ran a study with uh, American College of Prosthodontists and found that almost 90% of dental schools are now teaching digital dentures to their dental students. So kind of a unique time to be in education and to be a novice practitioner or even a more experienced practitioner that may be hiring a younger associate, that the environment is really changing as we switch from conventional to digital. I like to reinforce to my dental students that those foundational principles are so critical still, as you might go practice in an area that doesn't have access to digital, or you might have a patient that for some reason your scanner's not working or whatever. But certainly today in 2026, there's still a need for kind of both of those workflows. And we're scooching out of the early adopters, certainly getting into the early majority for digital denture workflows, particularly with immediate dentures. And we'll kind of go through some of the indications why digital lends itself more towards immediate denture workflows, even more so than some of the conventional workflows. I see a lot of removable prosthodontic patients, both in the student clinic and in my intramural private practice. And my personal opinion, so this is Wendy's bias, nothing scientific. I will occasionally still do some conventional denture workflows, depending on the patient, but never will I ever do another conventional immediate denture. So we'll kind of walk through the difference on why we see that and how that lends toward the workflow in that way. So what is an immediate denture? An immediate complete denture is going to be any removable prosthesis that's placed within about 24 hours of tooth extractions. So when you take out teeth, patient leaves with a denture. It doesn't have to be delivered essentially that exact same appointment. It can be within the next day. So a lot of times my patients that are in the OR, for example, the surgery will be on one day and then they'll come see me the next morning to deliver the immediate dentures. But as long as it's within that 24-hour time frame ish, it's still considered an immediate complete denture. And for all the people that find that they don't love dentures, I find even less love for my immediate complete dentures when I talk to my colleagues. I think part of the reason is that they're confusing. I had asked AI to help me with an image when I was teaching immediate dentures to my dental students, and this is what AI thought immediate dentures were. And I'm very confused even by this photo. The workflow is a little bit different than what you learn for conventional dentures. It's complicated by some of the surgical considerations. And so certainly for a novice clinician or for somebody that doesn't do a lot of removable prosthodontics, understanding the workflow and the sequence and the timing can be quite confusing. And they can be a little bit intimidating. We don't do a complete try-in ever for an immediate denture. So no matter how perfect the case is, there's always going to be that element of not being 100% certain what it's going to look like or feel like or function like at the time of delivery. But truly, it's such a service to provide our patients. We have a lot of people that come in with failing dentition and they just don't want to be without teeth. They might have a forward-facing job, or they might be around their kids or something where they just can't be without teeth for psychological purposes. So even though there are more complexities and more technique sensitivities to the workflow, certainly it's a service that's very, very critical for a lot of our patients. So the advantages are a little bit more obvious. Not only does the patient maintain that appearance of dentition from start to finish, it also helps control the surgical site. So by creating a surgical stent, which we'll talk about a little bit, and by placing that denture in at the time of surgery, we start to contour the ridge in a more ideal way. It also helps support the facial soft tissues so we don't see as much collapse, and it's easier to recreate as we go through more definitive treatments. The disadvantages, I think, also may be a little obvious that we don't get to try them in. So they're much, much less predictable than our conventional dentures, which are already a little unpredictable. More technique sensitivity with kind of the treatment planning and the workflow, and more frequent post-op visits. This to me is one of the biggest points of miscommunication with immediate denture patients. A lot of them think the word immediate, that they're going to have their teeth out, get their denture, and be done. But certainly with the swelling and the soft tissue changes that occur in the first year, you're going to have to see that patient more often and the work done at each post-insertion appointment is going to be more complex than a conventional denture. So I think it's important to communicate kind of the lack of predictability and the number of appointments and time you're going to be committing. There are two types of immediate dentures, and this is where my dental students always get confused. So I want to make sure that we focus a little bit on this terminology. A conventional or a classic immediate denture is what we learned about when I was in dental school, where it's a definitive restoration. So you're going through all the steps, you're basically following a very similar workflow that you would with a conventional complete denture, with the intention of that immediate denture being the patient's permanent or definitive prosthesis. Because of all those tissue changes that are invariably going to happen, you should also treatment plan a laboratory hard reline. So even if you're considering this as your definitive restoration, at the onset of treatment planning, the definitive laboratory hard reline should be discussed. So this immediate complete denture, and these are the CDT codes up here, the D5130, D5140 for maxillary mandibular. This does include the follow-up care. So for the first few months after treatment or the first 1 month, depending on your office policy, the D code should include any tissue conditioning or adjustments that you need to accommodate that healing. It does not include the definitive laboratory hard reline or rebase. So typically when you drop in this D5130, D5140, phase 2 of your treatment plan should be that indirect laboratory reline. And this is just outlining that. So for maxillary mandibular, the indirect laboratory reline will be that D5750 or D5751. The second type of immediate denture, which is usually what I try to do in my practice, is going to be what we would call an interim or a transitional denture. So this is still an immediate denture, but it's an interim immediate denture. And this is intended to be used for a definitive period of time. The CDT code specifies about a year, so this should be replaced within 12 months. And then at that time, you'll remake the dentures. So this workflow, you would treatment plan an interim immediate denture, which is a different D code. It's going to be 5810 and 5811. It's usually a little bit less costly from a laboratory for the fee that you pass on to your patient. And then after the healing period of 3 to 12 months, you'll replace that with a definitive restoration, a conventional complete denture, D5110, D5120. So again, the two phases are going to be interim immediate, followed by a definitive complete. With the alternative treatment plan, we have the conventional immediate, followed by a laboratory hard reline. So I present two different treatment options to my patient that we can choose. So once you've elected which one you're going to choose, you'll start to proceed with the appropriate workflow. I'm going to start with a classic immediate just as a refresher from everybody's time in dental school. Typically with this workflow, it is going to be our definitive prosthesis. So we want it to fit as well as possible. So we will typically do a phased extraction where we remove the remaining posterior teeth and allow those to heal. At least 4 weeks. Usually we'll wait a little bit longer if we can. And that will allow the posterior area with the hamular notch, tuberosity, posterior palatal seal to heal to where it's going to be pretty close for the final denture, which allows you to capture that more in your impressions. So we're going to acquire our records, and for our conventional records, we're looking at casts, face bows, interocclusal records, all that good stuff. And you can see the definitive impressions. If we will typically, if the patient's dentition allows, make a custom tray and border mold that posterior segment. Because again, this is going to be pretty close to the support bearing area for our definitive denture that after everything heals in about 6 to 12 months. So here we're going to border mold the posterior area, hamular notch, tuberosity, posterior palatal seal, and try to capture as much definitive anatomy as possible. If your patient has a lot of bridge work or a lot of periodontal disease, oftentimes we do not want to do a custom tray impression. And I laugh so I don't cry because I just had to section one of these out of a dental student's patients um, for them. So it got to be a little bit challenging. So this is a really important diagnostic criteria that if your patient has dentition that is very, very compromised from a periodontal standpoint, or has a lot of crown and bridge work where the PVS can lock in, you might want to consider an alginate impression for your final impression. It's still ideal to do phased extractions, even if alginate is your final impression material, so that you can capture all that anatomy as closely as possible to what the patient's going to be like when they heal. So again, phased extractions, definitive impressions, usually a custom tray if possible, ideally border molding if conditions allow, or alginate if the patient doesn't have a favorable dentition. Okay? Because the patient's now missing all their posterior dentition, we're going to follow kind of that more conventional workflow with a record base and wax occlusion rim and do a conventional jaw relation record where we're establishing vertical dimension of occlusion, our horizontal relationship of centric relation, a face bow and tooth selection. Here, the laboratory will start to arrange the teeth that are missing, and you can do a partial clinical try-in or a wax tooth try-in if the patient's missing dentition allows. Again, you don't have to do this step, but because this is going to be the definitive prosthesis, we want as close as possible to ideal denture for our patients. Okay? So once we've tried everything in, we know where we want the teeth to be. Now we can partner with our dental laboratory to start modifying the cast to fit what our definitive denture will be. So some patients might need a little more alveoloplasty. Some patients might need to level the ridge out some. Some might have some undercuts that need to be removed. But we know where the teeth are going to be, and we want to remove the stone to accommodate those teeth. And so the laboratory is doing this in a very conventional manner. Again, removing the stone teeth from the cast, contouring it to our specifications. So typically we'll look at an x-ray. We look clinically, how much bone loss does the patient have compared to the tissue, and we'll tell the lab, remove 3 millimeters of bone from the anterior to match the level of the posterior or whatever that may be. So we cater to our patient how much bone or stone to remove when we talk to our laboratory, and they'll arrange the teeth accordingly. When you're doing a lot of alveoloplasty, you certainly want a surgical stent to help guide that. Typically, you'll see something like this middle slide here where it's a hard resin. This can now be 3D printed. It might be a vacuform. It might be a processed acrylic or a cold cure acrylic. But basically, we're replicating the intaglio of the denture with some sort of clear matrix that we can utilize at the time of surgery. So this stent is made after the cast is contoured, and we usually make it at the time of denture processing. So it's after the cast has been modified and everything else. Okay. If you want to make this chair side, you can certainly do this with an Essex retainer. The thicker the Essex material, the more rigid it's going to be. If you don't have a laboratory cast, you can make one out of putty. You just mix some laboratory putty, put it inside of your denture base and adapt it really well, and basically make a putty cast of the inside of your denture. And this is showing one of the laboratory putties that you can use that's on the market. It doesn't matter which one you use. And you're just going to squish it inside the denture base and essentially make a little cast of your denture. Now that you have this putty replica, you can take it to your suck down machine and just pull a vacuform over it. And again, the thicker the material, the better. Once you have your denture finalized, we have our surgical guide. We can now process our definitive denture. This is showing very conventional denture techniques. This is a press pack acrylic. This is how I was trained to make dentures in dental school, and certainly a lot of laboratories are still doing this. Whenever we process conventional PMMA, there's always going to be that risk of polymerization shrinkage, where it pulls away a little bit from the ridge and you have that little bit of misfit. Once you see your patient, now we have everything planned, dentures in hand, surgical guides in hand. We're going to remove the teeth, and we want to make sure that this ridge is as smooth as possible so that the tissues around it can heal, and support that denture without having a lot of bony spicules or undercuts or tori or anything like that. And you confirm that the denture is going to seat by placing this clear surgical stent, like you can see in this upper right photo, pressing it against the tissue and making sure that there's not a lot of rocking once it's seated all the way. The nice thing about it being clear is you can see blanching where there's going to be a lot of interference, and that'll indicate where you might want to remove a little extra bone. Once the teeth are out, dentures being tried in, you can certainly now utilize conventional denture adjustment techniques to make sure that the denture is seated. We try not to put too much stuff around the extraction sites the day of surgery, but a little PIP will be okay. Just try to keep it more away from the sites if you can. We want the occlusal adjustment for the patient to leave at least with contacts bilaterally the day of surgery. The occlusion is going to change quite a lot as the swelling continues and then shrinks back. So occlusal adjustments will usually have to be done at each appointment. That's a pretty common thing to see. The day of surgery, you want your patient to wear the denture as much as possible for the first 24 hours. Ideally, they'll keep it in nonstop for 24 hours if it's retentive enough and if they're comfortable. And then when they come back, they can either do a phone follow-up or they can come in and see you at that 24-hour recall, and you'll remove it together to make sure that they're able to take it out, gently clean the sockets, clean the denture, and then put it back in place. Swelling peaks at 72 hours. So we usually advise patients to wear it as much as possible for those first 72 hours. After that, they can take it in and out as needed. If they don't wear it very much that first 24 hours, they can swell more uncontrollably, so that way they won't be able to put the denture back in for a few days. So if it's out and there's a lot of swelling, they may not be able to reinsert it. Having the denture in that first 24 hours helps control that swelling to kind of follow the intaglio of your denture. Usually we do follow-ups for the first week and then as needed for the first month or so. And then we have our patient come back for a 3 to 6 month reevaluation to see how everything is settled in. That's the point where we can start to reevaluate for a reline or a remake. If your patient is going to be getting implants, this is when you would take your CBCT and start to move forward with that treatment plan. So we take care of everything for the first month, then follow up only as needed. And then at the 3 to 6 month mark, that's where we reevaluate. Sometimes we end up adjusting so much if our occlusion was incorrect, or if we had to over adjust the base, or if it was underextended, or if the anatomy healed very unpredictably. Sometimes even if you were hoping for a hard reline, you still have to remake. But again, at this point, this is where we would do our impressions and follow up with that next step of care. Again, it's so hard to communicate to patients what to expect, especially if they start with a lot of teeth and they're going to a complete denture. It's such a drastic change. My attending in school used to compare it to two Tupperware containers and trying to eat with two Tupperware containers in your mouth. It's just so unpredictable, especially gagging. Sometimes patients don't know that they have a severe gag reflex until they put a denture in their mouth. And again, they're not getting the denture or even a complete try-in until all of their teeth are removed. So just to explain to patients the unpredictability of this process, it's not going to be easy for the first few months. And then after everything's healed and we can start fresh, then the predictability will pick back up. I think this is especially complicated when patients don't know somebody that's had an immediate denture, only a complete denture. And you'll hear a lot, well, so-and-so can eat steak with their denture. Why can't I? And just kind of explaining that whole process can be really, really critical, starting from onset when you're doing your treatment planning and then carrying it all the way through the healing period. So that's kind of my quick and dirty rundown of what we learned and what we've known for a long time about immediate complete dentures. Um, Now we'll roll into some of the digital workflows and talk a little bit about interim versus completes and how digital workflow plays into that. So anytime you're doing any digital workflow, whether it's immediate denture, a conventional denture, crown, bridge, all of the steps will fall into one of three categories. We're either acquiring data about our patient, scan, CBCT, photographs, etc. We're taking that data, putting it into design software, or we're taking that design and fabricating a prosthesis. For immediate dentures, we're taking some sort of impression, rolling into the design, and then milling or printing our final denture. With interim dentures, we're going to use a little bit different of a workflow. Your patient doesn't necessarily have to do the posterior phased extractions. I do interim immediates, especially when my patients have 28 teeth or they have severe periodontal disease or they have so many teeth and they don't want to go through multiple surgeries, saying it's not going to be super predictable to do conventional dentures. Let's recommend immediates. And so when we're deciding, you can do a full arch scan for pretty much any of your patients, but if they're missing a lot of their posterior teeth, particularly on the mandibular, a lot of times it's going to be hard to scan that soft tissue. So the more teeth your patient has, the easier it's going to be to capture a full arch scan in general. The next question is going to be whether or not they have an occlusal tripod. I talk to my students a lot about having a tripod in the patient's occlusion. When you have bilateral contacts in the posterior and an anterior stop, you have a three-legged table. So you can mount casts a lot more predictably. When you're missing any one of those 3 points, you no longer have a three-legged table. If you're taking physical models, that's going to be quite a challenge to capture that occlusal record without a record base. When you utilize an intraoral scanner, you can more predictably scan or capture the occlusion without that tripod. We'll talk about capturing that, but no matter whether you're doing conventional or digital, you want to make sure you're recording your patient's occlusion in centric relation. Here we're going to take photos to help with our diagnostics. We're going to request a digital preview, and then we're going to decide if we want to do an optional monolithic try-in appointment or if we're going to go directly to complete denture. Doing this interim workflow, if you don't do the try-in, and if you're able to do a centric relation scan, and you're able to do a final impression scan, you can do a very predictable immediate denture in just 2 appointments, where we're capturing all the digital data at appointment 1 and then going to the immediate denture. For me, I said at the beginning, I will not do another conventional immediate denture, and this is why. When I was working in Atlanta, we had a laboratory up on the 8th floor. We were in a high rise in Atlanta. Beautiful view of the city. It was right over the new Braves Stadium. And you could just sit and arrange denture teeth on a Friday afternoon while you're waiting for your emergencies and look over the city, and it was beautiful. So one summer day, I'm sitting in the lab bench arranging my immediate denture teeth, and I go home and come back Monday to find out that the power went out in Atlanta in the summer. And my little um, Whitmix 2240 articulator was sitting in the sun. And when I came back, my denture teeth were not in the same position that I left them. And that was very traumatizing for me to have to try to recreate this denture setup for my immediate denture patient, not knowing anything about how it was going to look now. I've lost all my landmarks because the first thing I did was grind off the stone of all my patients' denture teeth. So when you utilize digital workflows, you preserve everything. So you have your patient's pretreatment anatomy, you have where your patient's teeth were, you have their interocclusal record, any try-ins, any partial dentures they may have come in with. You have a record of all that so you can more accurately recreate what the patient had in a much more predictable way. When you're doing a digital immediate denture, you can still take conventional records. And again, this can go for immediate complete or it could be conventional or interim. So any of these can be conventional, digital, interim, or uh, classic. So you can mix and match all you want. No matter what workflow you choose, no matter what kind of denture you're going to make, you need to capture an interocclusal record. With conventional horizontal records, you can choose MIP, or maximum intercuspation. You can choose centric relation or neuromuscular. The somatic gnathic system, when your patient bites, relies on three things: muscles, teeth, and your TMJ. Maximum intercuspation is dictated by your teeth. Neuromuscular is dictated by your muscles, and centric relation is dictated by your jaw joint. When we have patients with teeth where they're failing and they're moving into an immediate denture situation, they have teeth still. So they might want to lock into this MICP position. But the day we take those teeth out and put the denture in, they no longer have MICP. And so this gets a little bit more confusing as we're working with immediate denture patients versus complete denture patients. Because complete denture patients don't have teeth, so we can't work with MIP, and we're not fighting MIP. We're only dealing here with either CR or neuromuscular. But it's easy to forget that MIP is not coincident with centric relation in 70% of our patients. So my one thing that I will encourage you to do, if you're not taking CR records for your immediate denture patients, if you switch to this, it's going to make your life immensely easier. And we'll walk through how you can do that with your scanner as well. So in other words, we're going to try to focus on taking a centric relation record no matter what with our immediate complete denture patients. So this patient came in, he had an existing partial retained by just a few maxillary teeth, and two of those teeth were non-restorable, and that didn't leave us with enough teeth to retain his partial. So for this patient, we plan to transition him from a partial denture to a complete denture, and we're going to do an immediate complete for him. For him, we took conventional impressions. And again, we want to establish our vertical dimension of occlusion, horizontal relation, and an orientation record. With very classic records, this is going to be vertical dimension with a wax rim, horizontal in CR, and a face bow. With digital, we can mix and match these a little bit. So here we actually did use a conventional wax rim to establish vertical dimension of occlusion as well as centric relation, and we recorded that position, the horizontal position in CR. We did not do a face bow. For our orientation record, we took a full face photo. So this is my next tip that I would encourage you to do if you want more success with your immediate dentures. First and foremost, take a CR record instead of MI. And the second is add a full face photo to your records. Here we are making sure that we can see both the patient's eyes, both the patient's ears, and their remaining dentition. This will allow us to roll into a digital smile design. And so I like to say digital smile design isn't just for fixed prosthetics anymore. We can now do this for our immediate and even our conventional denture patients. So here we have our patient with his existing partial, everything scanned in the purple. We have our proposed tooth arrangement with the white denture teeth here. This is how they look in the patient's face. And then we have how much we're planning to lengthen. Now we can show the patient this photo and he can approve or deny, or we can make all the changes we want before we extract their teeth. So even though we can't do a complete try-in, we can do a prototype or a virtual prototype with a photograph, and let the patient have a little bit better of an idea about what things are going to look like. Regardless of what workflow you do, I encourage you always to request a digital preview. This allows you to see where the dental laboratory is going to be positioning the teeth in relationship to what they already have. This is my third key to success. So CR record, full face photo, always request a digital preview. It was amazing. I was working with a lot of dental laboratories that every time I sent my immediate dentures out, they would come back set in a class 2 tooth arrangement. So no matter if they came in class 1, 2, or 3, when they left with their immediate dentures, they had 4 millimeters of horizontal overlap or overbite. And I'm like, what is going on here? And there was no way with conventional workflows for me to pinpoint what the problem was. And the lab kept saying it was my bite. And I kept saying, no, it's not. I don't think so. And I would try different bites and I would end up with the same result. But now with digital, we can see where the laboratory is proposing the tooth arrangement. And if it doesn't look the same clinically, then we know that there may have been a change in centric relation or something like that. But at least now we have eliminated that unpredictability of where the teeth are going to be in the final denture. In this case, my patient was missing all of his front teeth, so we elected to do a partial monolithic try-in. In this case, we design the full denture, we print the full denture, but we cut out the remaining dentition. So that way we can slide the partial monolithic try-in around the existing teeth, verify that we like the new tooth position, again, eliminating a little bit of that lack of predictability with immediate dentures. When we do any sort of monolithic try-in, whether it's partial or complete, this is a fantastic step-by-step checklist. Easy yes, no questions designed to work with auxiliaries so that we can start to see what changes we want to make before we go to our definitive prosthesis. In this case, we did a printed final denture. I worked on this case with my colleague, Ibrahim Dukum, who will do some fantastic presentations soon for NDX. In this case, this was the time of insertion, which was our immediate maxillary denture. And he was happy, went home happy. Now, I always like to reiterate that we cannot yet, I will go on the record for saying this, so I know this is being recorded, we cannot yet border mold with a scanner. I use intraoral scanners for everything. I'm scanning all sorts of stuff that I'm probably not supposed to be scanning, but I'll do it anyway because I love to play with my trios. However, you cannot border mold with a scanner. So typically when we're doing like some sort of digital denture workflow, I end up border molding in the monolithic try-in or something like that. But with immediates, we don't have a complete try-in. So when I go from my scan to my final immediate denture, there's not a chance for me to catch up and border mold for these patients. In immediate patients, we pick up border molding with our chairside reline. So typically, as a general rule, everybody's different, of course, but as a general rule, when you take an alginate impression, your impression is going to be overextended. By nature, that material is going to really push your tissue out of the way, and you end up with a super overextended impression. So a lot of times, if you get a really good alginate impression for your immediate denture, you have to do a lot of adjusting because your flanges are too long. With scanning, as a general rule, your impression is going to be underextended because we can't border mold with a scanner. It picks up fantastically that attached mucosa, and it'll start to pick up the unattached mucosa. But wherever there's frenum or anything overlaps, it's not going to get a clean scan. So with 2026 technology, and I'm sure it's going to change in the next few years, but today we're not going to get a good scan of the depth of the vestibule, which means our dentures are going to be underextended. The good thing about this is we now have room for our reline material. You can reline at the time of insertion if your denture is not super retentive, because again, we want the patients to try to wear it if possible. Typically, at the time of insertion, we'll use a tissue conditioning type reline that's a little bit, has more plasticizers in it, something like Co-Comfort or Linol. Both of those materials can be used for tissue conditioning, and they're both very kind to the tissue and will adapt to that surgical site very well. If it's extremely underextended, the Co-Comfort might not pick it up, and you'll want to use something with a little bit more body. In that case, you might want a Co-Soft or a silicone material like from Tokuyama or Rodin. A lot of those materials are with a silicone, you can border mold with those and extend your denture a little bit more. With digital dentures, you might be working with something milled, you might be working with something printed. There are a lot of different printed resins. This one, for example, this picture is actually a jetted printed denture. So this is a monolithic printed denture printed on the Stratasys. They all behave very differently. So printed dentures don't have as much, they don't have PMMA in it the way that a milled or a processed denture is. So when you use a PMMA reline like Co-Soft or Co-Comfort, it's not going to adhere the same way. So to me, it's important to know that you can reline any denture. So I don't have we are doing clinical studies on this, but there's not a lot of data right now on kind of the technique. There are lots coming out. There's a ton of literature right now about reline material. We have I have two that I worked on with different residents that have been published. But you want to get the material dry. So when you're working with printed resins, which we do a lot for our immediates, you want to roughen the surface and then get it super, super, super dry. So not just blow it with your air water, but wipe it with a 2x2. I even use alcohol in a 2x2 and then wipe it again with a dry 2x2 after I roughen it up. And from there, you can get the material to stick a lot more predictably. The silicone reline materials behave a lot like PVS. It's a very, very similar consistency, and it actually comes in, it attaches to your PVS dispenser the same way as your heavier light body or Regisil. Those are a little bit more adept to adhering to printed materials. It's a little less technique sensitive because they come with an adhesive or like a primer that will soften the resin and help it attach. So you actually do get a little bit of a chemical bond with the silicone materials. So if you're not having any luck with the regular plasticized PMMA materials like CoSoft, CoComfort, or Linol, you might want to look into some of the silicone reline materials. There's one from Rodin, one from DentureFit, one from GC, one from Tokuyama. There's a whole bunch of them right now. All right, so after 3 to 6 months with either an interim denture, whether it's conventional or digital, now we want to remake our denture. Because we already planned from the onset to do a remake, the patient's aware of the fees, they know the sequence, but now they have a starting point. So after 3 to 6 months with your patient wearing your interim immediate, you don't have to go back from scratch with alginate impressions. You can now utilize your immediate to do a reference denture workflow. So if you want to learn more about the reference denture workflow, this QR code will take you to a video that's 10 minutes long, goes through step by step. And certainly there's another resource on the NDX education site where we walk through different digital denture workflows and focus quite a lot on the reference denture. So no matter which workflow, we're going to start with our acquisition of data. For digital, it's going to be a scan. You want to try to make sure that you're scanning as much soft tissue as possible. So again, you can see that the scanner kind of stops at that mucogingival junction. It doesn't pick up the front very well, but please make sure you always scan your palate, and you want to try to get the tuberosities. You want to try to get your hamular notch. You want to try to get your retromolar pads, as much data as you can. So capture all the soft tissue you possibly can. After you've established your scan, which is going to be your final impression, now you need to get your horizontal record. And when we make dentures, whether they're immediate or complete, we're going to restore our patients in centric relation because they won't have their teeth anymore. If you're doing digital, this is a $5 tip. Scan your patient in centric relation. So in this case, we're using a little Lucia jig to separate the teeth and scan in an open bite. When you scan in the open bite, it's going to lock in that CR and relate the master cast to each other in that position. If you really want to take this to the next level and have more predictable immediate dentures, you can try to actually scan this at the correct vertical dimension. So a lot of patients, like the one that you saw in the previous scan, lose their posterior teeth. They're very collapsed, and you need to open that bite to reestablish the appropriate vertical and make space for your dentures. So you can utilize a Lucia jig or a leaf gauge to open the patient up to the vertical dimension you want, and then scan at that open bite in the correct vertical in the correct CR. And that's where you're going to get the best, most predictable occlusal results. Now we've gotten all our acquisition of data. We have our vertical record, we have our horizontal record, and we have our final impressions. We took our full face photo so that we can see where the incisal edge midline is, and now we can start our design. You can design yourself. So softwares are getting more and more predictable, easier to use, more cost effective. So a lot more clinicians are designing their immediate and complete dentures in-house, or you can delegate to a dental laboratory technician. And I mentioned before what's called the digital preview. This is when you outsource your tooth arrangement to your technician, you want to make sure that you've communicated effectively and that they've understood what you and your patient want. Because they haven't sat with your patient and communicated with them and heard their desires. So basically, a digital preview could be a photograph, could be a video, could be a Zoom, but you're going to have something come back where you have your reference. In this case, it'll be your patient's teeth, like you can see here in the blue. And then the white will be the laboratory proposed tooth arrangement. This is really nice because you can actually see when the patient has, or when the laboratory has opened the vertical dimension. So you can actually verify that the vertical is open or closed to your specifications. You can pre-visualize what the bony architecture is going to look like. So you can tell the laboratory to remove more or less bone before they finalize the denture. And you can see where the aesthetics are going to be in that incisal relationship, which is so critical for speech and aesthetics. If you haven't worked with a digital preview much, this is a really fantastic article out of Loma Linda where they do a checklist on how to review a digital preview. The digital preview can be something as basic as this. So this was one of my immediate denture cases that I sent to 3 Point Lab, and I asked for a digital preview, and they sent me the proposed tooth arrangement overlaid with a patient's existing teeth. And you can see we're shortening quite a bit on the central incisors compared to what the patient came in with. Here we have some hypereruption, and we've actually moved the occlusal plane up 3 to 4 millimeters. So now I can partner with my laboratory and say, you know what, we really like the length of number 9. Can you please reset the teeth so that they follow, I'm sorry, of number 8. Can you please reset the teeth so they follow the patient's existing central incisor? Or I may have asked for this. I may have said the patient's had hypereruption and I want to shorten that tooth. But without seeing this photo, the lab could be totally having a different artistic vision than you and your patient. And this really helps with that communication. And so you can see even this helps following the midline. This will get overlaid with a photo, and then we can start to plan. In a case like this, where we're raising the maxillary occlusal plane up so much, we're going to have to create space with alveoloplasty. So now I can see on the laboratory's plan how much bone they plan to remove and if that's something that's even feasible. So make sure that you always communicate with your dental laboratory technician during the process and ask for that digital preview before they go to the final restoration. And this is showing before and after. Again, this is one of the monolithic printed dentures and showing that occlusion, and we relined at the day of surgery. This is a really easy article. You'll have to create an account with Dentistry today, but this walks through the whole digital immediate process that I just showed you, and then also how it rolls into the reference denture workflow afterwards. So this is something that might be a nice resource if you haven't worked a lot with immediate dentures and you want to see the step-by-step breakdown again on a paper format on what that might look like. So in conclusion, we're starting to see more predictable immediate dentures with digital workflows and having that digital preview and having that virtual communication with our dental laboratory. So we'll finish this with one last video for an immediate denture case where we scan maxillary mandibular, get as much soft tissue as possible, scan in centric relation, take a full face photo, send that all to the dental laboratory so they can complete the design. We request the digital preview so we can see the virtual extraction and bone contouring to make sure it's what we're expecting. And then this is the key shot here is to ask for the superimposed pre-treatment and tooth arrangement. So you can see where the arranged teeth are in relation to the pre-extraction teeth. Then last but not least, we've gone acquisition, design, fabrication. This is a 3D printed denture case with carded denture teeth. So these are actually carded denture teeth and a printed denture base, maxillary mandibular, immediate denture, time of surgery. This is the result that we always want. And I would like to be very honest and tell you this is not my case. This is actually one of my dental students' first denture cases. And to me, that's so impactful because if my first case was a conventional maxillary mandibular immediate denture, I would be sweating and crying at the end of the day, where this patient and this student came out smiling out of the operatory. And it just goes to show how when you utilize these digital workflows and make the process more predictable, it not only changes the game for the patients, but also for our young dentists and our graduating dentists. So I am so happy to be able to teach dental students a workflow that isn't so scary and isn't so intimidating, where they can take that technology and make the process more predictable, where they still understand those conventional workflows and when a conventional impression is going to be a little bit more predictable. But now they can do a full face photo and they can do a digital face bow transfer and they can visualize the preview and they can communicate effectively with a laboratory that way and get a product that doesn't scare them and that their patient can be proud of and smile big. So to sum up, I agree with the Goodacre article that came out in 2021. I absolutely think that digital dentures should be a part of contemporary dental education. These are some shots of my dental students doing really cool digital denture work. We are making digital complete dentures and digital immediate dentures at the dental school, and we're trying to roll in even more where now students are starting to get more involved with the design process and learn a lot more about that and become more comfortable.